interesting talks, and we hope to accomplish that within the time frame. So it's my honor and pleasure to introduce the first speaker. She is Professor Cecily Quinn from Ireland. She is going to present us with the challenging subject of fibroepithelial lesions of the breast. Please, Dr. Quinn.
Sorry, it's not ready, sorry. Sorry, I need some help with finding the talk. Sorry. Sorry, yeah. You have it somewhere? Yeah. Oh yeah, all good girl, thanks. Session 2, oh yeah, there I am. Yeah, thank you, excellent. Thank you so much. Hold on, okay. Hi, good afternoon. Thank you very much again, and thank you again, Professor Manal, for the invitation to speak. So I'm going to talk this afternoon about another tricky area, I think, of breast pathology, fibroepithelial lesions of the breast. I think despite the fact that we see these lesions really every day of the week, they can still confound us and certainly challenge us. So in the course of this lecture, I'm going to basically talk about fibroadenoma, the classical fibroadenoma and the variants, and flotase tumor, focusing on classification into benign, borderline, and malignant, with a little bit of emphasis on what's new in the blue, as Gary says, so what's new in the blue book. So a fibroepithelial lesion is a classical biphasic lesion. That is a lesion with two different cellular elements. And we'll see as we go through the topic how these vary between different entities. I'd also like to mention in the course of the lecture the various issues really that arise for the pathologist and at the MDT in the management and further workup of these lesions. So to start with fibroadenoma, they're very common. They usually occur in women between 20 and 35 years, presenting as a painless, palpable, firm, mobile lump. They used to be called, when I was a medical student, a breast mouse. I don't like mice, so I used a modern version to illustrate. And this is because when you try to palpate them, they dart away from under your fingers, unlike something malignant. However, despite the fact that they're more common in young women, we all have seen that mammographic screening has led to the detection of asymptomatic, smaller fibroadenoma in older women. And this is the classical appearance on radiology. The gross appearance lesions are usually, but not always, less than 3 centimeters. We've all very familiar with these. They're circumscribed, the cut surface is white, and the consistency is firm. On microscopy, the key feature, I think we could turn the lights down maybe for the images, please, is the presence of this balanced, evenly distributed proliferation of glands and stroma. And I find this phrase really very useful really every day when you're trying to decide on a core biopsy if you're dealing with the fibroadenoma or perhaps with the flotase tumor. So the balanced, evenly distribution, thank you. So on the left-hand side, you can see the typical pericanalicular configuration, and on the right, the intracanalicular. So when it comes to the stroma of a fibroadenoma, it's typically low in cellularity, with no significant atypia or mitotic activity, except, however, in young or in pregnant women. We do not see overgrowth. The stroma tends to be loose and mixoid in younger women, but more hyalinized in older women, as you can see in the lower picture. So it's very common to see additional stromal changes, including giant cells, calcification, lipomatous or smooth muscle metaplasia, and sometimes PASH. So we see all of these changes in fibroadenoma. However, we can also see them in flotase tumor, so they don't really help us in that distinction. It's also quite common to see additional epithelial changes, and you can see the entire range of epithelial change that you see in the breast in general, including epithelial hyperplasia, sclerosing adenosis, DCIS, lobular neoplasia, and any of the epithelial conditions. So the full spectrum may be evident within fibroadenoma. Somebody mentioned the complex variant before lunch, and this is something that is quite common. It accounts, believe it or not, for 16 to 23% of all fibroadenomas, and it is defined as a fibroadenoma with one or more of the following 4 features: the presence of cysts that measure more than 3 millimeters, sclerosing adenosis, epithelial calcification, and papillary apocrine change. So any of those features qualifies the fibroadenoma as a complex variant. Sometimes these lesions, these changes are very prominent within a fibroadenoma, and I've seen cases where on core biopsy, the epithelial changes are so complex and so well developed that it's almost difficult to appreciate that the lesion is a fibroadenoma. So this is where, of course, correlation with radiology is very important. Is the radiologist seeing a circumscribed lesion, or are they seeing an irregular area of benign change? With regard to classification on core biopsy, these classical fibroadenoma complex and other variants are B2 lesions and do not require further excision unless there's a particular reason to do so. But I'll mention that again later on. Now, the cellular variant of fibroadenoma is really one of the most problematic lesions in breast pathology. The key feature is the presence of increased stromal cellularity, and these are very challenging on core biopsy. Are we dealing with a cellular fibroadenoma or a benign flotase tumor? So usually cellular fibroadenomas tend to be pericanaliccular and not mitotically active. Less than 2 per 10 high power fields, or the WHO has now given figures for digital microscopy, so it would be less than 1 mitosis per square millimeters. So a cellular fibroadenoma should not display the architectural features of flotase, stromal cell atypia, overgrowth, intralesional heterogeneity, which again I think is a very useful finding, and neither should we see subepithelial stromal condensation. So they are features of flotase tumor that I'll talk about in a few minutes. However, if you have a lesion on core biopsy and you're finding it difficult to distinguish between a benign fibroadenoma and a benign flotase, it is reasonable to report these lesions as a benign fibroepithelial lesion, or favouring a cellular fibroepithelial lesion, giving this a B3 designation and suggesting excision to ensure that you get the diagnosis right. The juvenile variant of fibroadenoma is uncommon. It occurs in adolescents and young adults. However, it's characterized by very rapid growth, and it may get to a very large size, and it's often called a giant fibroadenoma. Now again, you see increased stromal cellularity, no significant atypia, usually not mitotically active, but that's not an absolute. Sometimes we do see mitoses, and we often see gynecomastoid type hyperplasia. So again, if we're confident of the diagnosis on core biopsy, we would say B2. However, these are often very large. They're very uncomfortable for the patient. The patient is young. So very often they are excised, not because of the pathological findings, but because of the clinical findings. So again, putting all the information together. The Mixoid variant of fibroadenoma is interesting. It's characterized by very prominent stromal myxoid change. Now, this is usually quite obvious on histology. We know that these tumors are associated with the Carney complex. They're usually sporadic, however, and they can actually mimic mucinous carcinoma on core biopsy. You can see those 2 pictures side by side. It would be rare to confuse them, but just bear in mind, if you see a very myxoid lesion, you're thinking of calling it mucinous carcinoma, just ask yourself, could it be a myxoid fibroadenoma? And again, of course, both lesions will be very circumscribed and often mucinous carcinomas look pretty bland radiologically, so the radiological findings may not be that helpful. When I first became a consultant in Leeds back in the 90s, every time I saw one of these myxoid fibroadenomas, I used to suggest the possibility of Carney complex. So after a while, the surgeons said that they were tired of referring these patients for cardiac workup, and would I stop putting that comment on my report? So I did, and I don't do that anymore, but I do report myxoid fibroadenoma when I see it. So the differential diagnosis is clearly the big differential is cellular fibroadenoma. Other differentials are fibroadenomatoid nodule, tubular adenoma, hamartoma, and nodular pash. So in the interest of time, I'll just show the pictures quickly on those. Fibroadenomatoid nodules very often present with calcification. They, interestingly, sometimes come as R4 lesions because they're composed of coalescent nodules, and they may look irregular or have a lobulated outline on radiology. But we see these very frequently as a cause of calcification that presents through screening. Clearly, a tubular adenoma is very circumscribed, closely packed glands. It's not a biphasic lesion. It's a proliferation of glandular structures that are closely packed. Hamartomas, these are often interesting, I think, because often you just get a core of what looks like normal tissue. Sometimes you'll see pash, maybe some interspersed adipose tissue. Again, they're not really biphasic lesions as such because we haven't got proliferation of the glandular component, but they can, if we see this on a core biopsy, very often we say it's B1 because it looks like normal tissue. We go to the MDT. The MDT says this is a circumscribed lesion. It's well targeted, so then we can say it's concordant with a hamartoma. So just because we say it's B1 does not mean that it's non-diagnostic or that the patient has to have an excision. So that's the purpose really of the MDT, putting everything together. Nodular pash is really a variant almost of hamartoma and turns up from time to time. So the prognosis of fibroadenoma, most lesions do not recur following excision. However, adolescents do have a tendency to develop further fibroadenomas at the same site or in the vicinity. And interestingly, the complex variant is associated, according to the published literature, with a slightly increased risk of subsequent malignancy. But we still call those B2s unless there's any coexistent atypia. There's been a lot of work, particularly in Asia, by Pui-Hoon Tan on genetics in fibroadenoma. And interestingly, this MED12 exon 2 mutation has been reported in up to 60% of fibroadenomas, interestingly not in the Mixoid variant. These are present in the stroma. They also occur in uterine leiomyomas, and other mutations are rare, however, in fibroadenoma. So when it comes then to the management of a fibroadenoma, if you have a needle core biopsy with classical features of either a typical fibroadenoma or a variant with no coexistent lobular neoplasia or ductal atypia, then it's perfectly reasonable to discharge the patient if everything agrees, if the pathology is concordant with the clinical and radiological findings. Consider excision if the patient wants the lesion removed. If it's growing, sometimes we'll get a biopsy from somebody and we'll diagnose fibroadenoma. Then 2 years later, they'll have a repeat mammogram and it will have enlarged. Now, it might still be a fibroadenoma, but usually in that situation, we would recommend excision. Size alone is not an indication. In our unit, we used to always recommend excision if the lesion exceeded 3 centimeters. One of my radiology colleagues went back and looked at all of our lesions of that size and greater and found that if everything was concordant, we had no unexpected flotase tumor. So we don't do that any longer. We just, regardless of size, if the lesion is not removed unless there are other indications. So, time. 17, okay, thank you. So moving on then to flotase tumor. These are much less common. They tend to occur in older women, and they are much more frequent in Asian women. Now, if you look at the WHO 2019, they define flotase tumor as a group of generally circumscribed fibroepithelial neoplasms with prominent intracanalicular architectural patterns, leaf-like configuration with bilayered epithelium, accompanied by stromal hypercellularity. So the two key features are the architecture and the stromal cellularity. So in terms of presentation, it's similar to most fibroadenomas, usually a firm, painless, mobile mass. However, as you know, these can attain a very large size. The average size is 45 centimeters. However, again, screening has led to the detection of smaller tumors. Now, large flotase tumors may cause skin ulceration, but these are not necessarily malignant. However, if you see a polypoid fungating flotase tumor like this one, which, believe it or not, presented to our unit during the COVID era, and these are invariably malignant. So this was unfortunately in a professional woman who had chosen really not to have intervention until then. Radiology, we often get very helpful information from radiologists, and they often describe cystic spaces. So when you get that information with a core biopsy, you're obviously on alert for flotase tumor. The macro, similarly, we may see a very circumscribed outline with a rather bulging configuration, and then this fleshy cut surface with varying degrees of cystic degeneration. So as I said, the two key features are the leaf-like architecture and the stromal cellularity. And the relative proportion of one to the other can vary. If you have a very well-developed architecture, I think the diagnosis tends to be more straightforward, but sometimes you can see very, very cellular lesion, but with a poorly developed architecture. And I know I got caught out on one of these in the EQA scheme a few years ago, where I didn't focus enough on the cellularity and misinterpreted the lesion as a fibroadenoma, when in fact it was a flotase tumor, but with a poorly developed architectural pattern. So this is just a table, which is, the print is probably too small to read, but this is taken from the WHO book. And this focuses on, it's very helpful on how to categorize flotase tumor into the various groups. So the key features are the tumor border, the cellularity of the stroma, the atypia, mitotic activity, overgrowth, and the presence of heterologous elements. This table also gives the relative proportion of the different types, and you can see really, if you can, that malignant flotase tumors are really quite uncommon relative to benign, and obviously flotase tumors are less common than fibroadenomas. So a benign flotase tumor is usually circumscribed. You may see very small buds going out into the stroma, which does not necessarily mean that you can't have a benign classification. The stroma is typically more cellular than fibroadenoma. However, in a benign flotase tumor, we do not see true overgrowth. We also see this typical subepithelial stromal condensation, where the stroma around the spaces is more cellular than the rest of the stroma. I think that can be a helpful finding. With regards to the stroma, the nuclei tend to be monomorphic. Mitosis should be less than 10 per 10 high power fields, or less than 2.5 per square millimeter. Another feature of the stroma that is helpful is heterogeneity. You can see quite a varied appearance in a flotase tumor that you don't see in a fibroadenoma. So this can actually give the impression of a fibroadenoma on a core biopsy. You can see here, hopefully on the left-hand side of the screen, almost a dividing line between a cellular area on one side with not very much glandular proliferation, and then an area the other side that looks more like a fibroadenoma. So again, this emphasizes the importance of radiology, pathology configuration. So if your radiologists are telling you this is very cystic and looking like flotase, and if you're having something that looks like fibroadenoma, well, that is not concordant, and that lesion should be excised for full evaluation. With regard to the glandular features, Abir showed us some nice animal shapes earlier this morning, and again, these crop up in flotase tumor. where you see these dilated, irregular glands with this side branching. And a useful finding is if you try to close out the space in your imagination and you're not able to do so, that's more likely to be phyllodes than to be fibroadenoma. So you can't close out the space with imaginary compression. And again, you can see the nice giraffe here and a similar configuration in the phyllodes tumor. Again, like in fibroadenoma, it's very common to see additional stromal and epithelial changes, so they do not help the distinction. So the biggest problem really with benign phyllodes tumor is clearly differentiating it from fibroadenoma on needle core biopsy. And this is a paper from Gary Say and his colleague, in which he emphasizes that really no single feature reliably distinguishes one from the other on core biopsy, and that even on excision there is a level of discordance. Clearly they are both indolent lesions, but the management differ. So the pointers that he gives to making a diagnosis of a benign phyllodes on core are fragmentation of the cores, and that is because if the lesion is cystic and the radiologist goes in with a needle, so they get fragments of the lesion, whereas in a fibroadenoma they get a nice core or more of tissue. Increased cellularity, except obviously in cellular fibroadenoma. Mitoses may be present, but they're obviously not very frequent. But again, of course, we can see these in some fibroadenomas. Adipose tissue, stromal expansion, condensation around ducts, and CD34 positivity can be helpful. Clearly, we don't routinely use immunohistochemistry. It's very much a diagnosis based on morphology, taking account of the radiological findings. I do find fragmentation and cellularity to probably be the best. And again, as I said earlier, if in doubt, report as a benign cellular fibroepithelial lesion B3 and suggest excision. So then just briefly then, malignant phyllodes tumor, WHO requires 5 features for diagnosis. Infiltrative outline, increased stromal cellularity that is diffuse, unlike the benign variants where it's variable. It should be diffuse. Marked stromal nuclear pleomorphism, stromal overgrowth, which is the absence of epithelium in one low power field. We often hear this term used in phyllodes tumor, but in fact, according to WHO, you really shouldn't see stromal overgrowth in a benign phyllodes. It's a feature really of malignant and sometimes borderline. And mitotic count should be greater than 10 per 10 high power fields, or greater than 5 per square millimeter for digital microscopy. The important thing about malignant phyllodes is that it is staged and treated as a sarcoma. So I do find that applying the 5 strict criteria, okay for time, I have a few minutes left, yeah, sorry, is very helpful. So if we want, just a little word then about malignant heterologous elements. If we see malignant heterologous elements, such as bone or cartilage, in a phyllodes tumor, that means that it's malignant even if it's otherwise benign or borderline. Now, it would be rare to see it in benign, but you might see it in borderline. So if you think you're not quite there for malignancy, but you have these elements, well then it is malignant. However, the exception to that rule is the presence of well-differentiated liposarcoma. And this is an example of a phyllodes tumor with well-differentiated liposarcoma. The phyllodes tumor otherwise was not particularly atypical and really probably would have been benign. So that is a change in the WHO 2019. The metastatic potential of these lesions is very low when well-differentiated liposarcoma is the only heterologous element in an otherwise benign or borderline phyllodes tumor. So you do not diagnose malignant phyllodes based on this finding alone. Now, Abir will remember we had a lot of discussion about what you would call these in the updating the UK guidelines, and it was generally agreed that if you did have well-differentiated liposarcoma and nothing else, you would probably go for borderline. But to say that it was benign might be a little a bridge too far. So I'm not going to dwell on borderline. Like all things in pathology, a borderline phyllodes tumor has some, but not all of the features of malignancy. So if you apply the criteria strictly for benign versus malignant, and it doesn't fit either, then you're probably in borderline territory. A periductal stromal tumor is where the stroma follows the ducts. It doesn't form a discrete lesion. It is biphasic. It doesn't have the typical architecture. However, it is now regarded by WHO 2019 as a proper variant of phyllodes tumor, and it is graded using the same criteria. Fortunately, these are rare lesions because I think really grading them is quite challenging. So the differential diagnosis of a malignant phyllodes tumor is really that of a malignant-looking spindle cell lesion, which we've discussed earlier. Again, take account of all of the information, thorough sampling, we talked about cytokeratin and CD34. So when it comes to the genetics then, MED12 mutations are present in the stromal cells, less frequent in the malignant phyllodes tumors. So that may be helpful in the future in categorization. Some new additional mutations, including TERT mutations, have been identified, and perhaps these will become likely to be helpful in diagnosis in the future. There are also mutations of the cancer driver genes identified in phyllodes tumor that may promote the biological progression. So the prognosis then, most are benign. The usual problem with phyllodes tumor is local recurrence. If they do recur, they tend to recur within 3 years of diagnosis, and they do tend to be of higher grade. The average rate of recurrence is reported to be 21%. So that brings up the next big MDT question then. What is the optimal margin width? Now, until relatively recently, all phyllodes tumors were recommended to be excised with a rim of normal tissue. However, that has changed in recent years, and the question then, if you have a definite phyllodes tumor on a core biopsy, should you be going for an excision diagnostic or for a proper wide local? And similarly then, if you have a phyllodes tumor on a diagnostic excision, does the patient need a re-excision or not? This is a big study published in 2021 from 11 institutions, including 550 patients with phyllodes tumor. Now, the majority were benign, 70%, with malignant ones accounting for 10%. And interestingly, at 3-year follow-up, there was a relatively low incidence in this series of local recurrence. It did occur in all grades, and it was not reduced by margin width. But the predictors of local recurrence were certainly the biology of the lesion, the grade, the size, the atypia, and the overgrowth. So it's quite a comprehensive, detailed analysis, and the conclusions are that the current guidelines now, which were until then, which were for re-excision of all phyllodes tumors, would be endorsed for the treatment of borderline and malignant phyllodes tumor, and not to recommend re-excision of a benign phyllodes tumor regardless of the initial margin width. So if you have a benign phyllodes on core, then you recommend excision, but not necessarily more tissue. If you think it's borderline or malignant, your surgeon should take a rim of normal tissue. And similarly then, if you've got a benign phyllodes tumor on excision, it is reasonable to follow up that patient rather than to re-excise. With regard then to distant metastases, and axillary nodal metastases are rare. Distant usually occur rarely in about 2% of patients, almost exclusively, as one would expect, in malignant variants, and it usually comprises stromal elements only. And the big predictors really of an aggressive clinical course are the size of the tumor and the presence of malignant heterologous elements. This is another paper from Emma Draka and colleagues, and in their study, they did find that excision margins tended to correlate with local recurrence, but very much that the tumor biology correlated with metastatic behavior. So to conclude, what is the future for fibroepithelial lesions? The talk we heard from Daniel earlier on was fascinating and really brought us into a world that we look forward to being in, where we have a lot of assistance with diagnosis, but we're not there yet, I think. Possibly the future for fibroepithelial lesions will be using mutational studies to decide A, if it's a fibroadenoma or a flotase tumor, B, to categorize, and C, to predict. However, life's not quite so straightforward at the moment, and usually the pathologist is confronted with an array of very, very different appearing lesions, ranging really from almost like normal breast tissue to high-grade malignancy. So for the moment, I think it's back to the microscope and the naked eye, and we do our best, taking account of everything, all of our information and all of the features. And again, always keeping an eye to the clinical and the radiology. I think the subject is very well updated in the WHO 2019. I love the online edition. It's so easily accessible and gives you very nice images that you can magnify, etc. The topic has also been very nicely updated in the Virchow's Archives Breast Edition by Pui Hoon Tan, Andrew Lee, and Melinda Lerwell, and certainly that's worth a read. So again, I'd like to thank you for this great opportunity. I'll leave you this time with some pictures of Ireland. Here we have Dublin, the Liffey, then we have some mountains from the west of Ireland, Ashford Castle, if you feel like a rare treat, and a picture from Galway, where I went to university. But I promise you, it's very cold at the moment, so don't book any flights just yet. Thank you very much.
Thank you very much, Dr. Quinn, for this great talk. It's my honor to